Screening for hepatitis C has become as part of the forefront of our efforts to combat this relatively silent epidemic worldwide of hepatitis C. Screening gives us the advantage of identifying patients and helping to prevent progression of disease. By identifying these patients with silent hepatitis C, we can advise them about the risks of alcohol consumption, the risks of transmission to others, and important lifestyle modifications that can help them in managing their disease. Screening guidelines vary from country to country, and recently in the United States, a guideline was suggested by the Centers for Disease Control and accepted by the Public Health Service that we should screen those at highest risk of hepatitis C, which includes not only those who have risk factors such as prior exposure to intravenous drugs, blood transfusions, and surgeries prior to 1990, but also people born in the generation of 1945 to 1965, the so-called baby boomer generation. The rationale for this screening is that this will help us identify those people who have the highest prevalence of HCV and will help us guide these patients either to preventative measures or potentially to new therapies that are on the horizon. Having said this, each country has to identify from their own epidemiological database what is the best screening program for that country. Once you've identified who should be screened, the real next question comes, how should we screen these people? And this really depends on what resources are available for screening. Traditional screening has been done by performing a once-off HCV antibody test, which requires a serum sample, which is then screened by an ELISA test for hepatitis C antibodies. If you test positive, these patients would then go on and have HCV RNA testing to see if they're actually infected, and then get counseling, education, and referral to appropriate care and experts in the field of HCV. Some newer advances that have taken place in HCV screening include new technologies that enable detection of HCV antibodies using point-of-care tests. Point-of-care tests have some certain advantages. They can be done in less resource-intensive spaces, such as a doctor's office or in clinics where there might be a high prevalence of hepatitis C, such as methadone clinics, and they usually involve more simple tests than requiring phlebotomy for serum samples. Two really good examples that are now being used on a worldwide basis are blood tests using finger sticks. And these finger stick blood tests really look for antibodies in a drop of blood using a very similar technology to how we actually do pregnancy tests today with urine. And this can be very effective in terms of more than 95% sensitivity and specificity for diagnosing hepatitis C, and so these tests are excellent for use in the community. Even better than a finger stick would be if we could obtain, for example, another body fluid such as saliva and look for salivary excretion of HCV antibodies. And there are now salivary tests that can look at the presence of HCV antibodies in saliva, again with a 95% sensitivity and specificity. So this enables us as clinicians in areas where we don't have access to laboratories to actually test the patient and within a short period of time, 30 minutes to an hour, get these results back so that we can discuss with the patient their results and actually start the process of education, referral, and linkage to care for these patients. So I think they represent a big advance in how we approach this. The future is also very bright if we can develop tests that can look for actual HCV RNA in similar bodily fluids. This would enable us to bypass antibody testing, actually determine at point of contact whether a patient is viremic, so that those patients could immediately be counseled as to whether they needed therapy and given the appropriate counseling for risk of transmission and disease progression. So we really need to now focus on even developing more tests and more specific tests for viremia for these patients at point of contact. I'd like to summarize by saying that, if we look at the global population with HCV, screening is something that each and every nation has to determine how it's best done and in which populations. But it has inherent benefits, not just when we're talking about who should have therapy, but also when we're talking about other issues, particularly in less resource-rich nations, about risk of transmission, counseling patients, about talking about alcohol and other things that can cause the disease to become worse. Even by doing that, we can make an impact on the natural history of HCV. So I am an advocate for screening. I believe it's very important. I believe it's important globally, not just to help more patients get into therapy, but also to reduce the disease burden of hepatitis C.